Welcome everyone. First of all, I would like to thank Ivona and Chip for giving me the opportunity to present our data today here. I'm going to talk about deficiency of adenosine deaminase 2 in a cohort of patients with PAN, polyarteritis nodosa. So this is the outline of my talk. First, I tell you a little bit more about PAN. Then I tell you why this is important to know about deficiency of adenosine deaminase 2 when you treat a patient with PAN. Then I tell you about the objectives and the cohorts and the results of our study. Then I summarize and I give at the end some recommendations, what we think is important. Okay, polyarteritis nodosa, in short PAN, is a necrotizing systemic vasculitis that mainly affects medium-sized arteries. So this type of arteries. And in contrast to other types of vasculitis, such as microscopic polyangiitis or granulomatosis with polyangiitis that can also affect the medium-sized vessels, it is antineutrophil cytoplasmic antibody negative type of vasculitis. It can be caused by viral infections, such as hepatitis B virus, but the cause of idiopathic PAN is still not known, not understood. And the usual age of onset is between 40 to 50 years. So most of the patients present in this age. The pathogenesis of PAN is still not completely understood, but it is postulated that inflammation in medium-sized arteries leads to fibrinoid necrosis. And this then in turn results into weakened blood vessels and causes aneurysms and vascular lesions. So here aneurysms, and you can see this skin finding. Okay, and this then leads to manifestations such as general findings, including fever, fatigue, or weight loss. Neurologic manifestations are described, mononeuritis multiplex or peripheral neuropathies, and also cutaneous finding, including levator reticularis, ulcers or rashes, and also renal and cardiovascular findings. So, unfortunately, PAN is still associated to a significant morbidity and mortality, and the 15-year survival rate of treated PAN is only around 60%. So, and the relapses are quite high, with up to 20% of idiopathic PAN. And the treatment options of PAN are limited and usually consist of glucocorticoids in milder cases, and in more severe cases, a secondary immunosuppressive agent is added, such as cyclophosphamide. So, and as you all know, in 2014, our group and a group from Israel described a deficiency of adenosine deaminase 2, and especially the group from Israel saw that these patients present with polyarteritis nodosa-like manifestations. So some patients with ADA2 have clinical and histopathological findings of PAN, such as levator reticularis, fibrinoid necrosis, and also aneurysms. And that's why we want to know the prevalence of ADA2 in patients who present with, or who have sporadic, or who were diagnosed with sporadic idiopathic PAN. Therefore, we investigated a cohort of 117 patients with idiopathic PAN. And these patients all met the American College of Rheumatology criteria for the classification of PAN from 1990. And importantly, they were all tested negative for hepatitis B virus infections. All patients were ascertained by the Vasculitis Clinical Research Consortium, and to our knowledge, this is the largest longitudinally followed cohort of idiopathic PAN. So what we did, we sequenced the complete ADA2 gene in these 117 patients, and we also tested the ADA2 enzyme activity in available serum samples. And what we found that 4 of these 117 patients, this is 3.4%, actually have biallelic rare missense variants in ADA2. And this table shows you the patients and their variants. And of these 4 patients, they had in total 7 distinct variants, because patient number 3 was homozygous for a variant. And of these 7 distinct variants, 6 were reported in ADA2 before, though they are pathogenic variants. And they also, as expected, predicted to be deleterious on protein function by in silico prediction. Interestingly, the age of onset of these 4 individuals was significantly younger than in the rest of our cohort. So we were able to get serum samples for 2 of these individuals, and we could confirm that their ADA2 enzyme activity is as low as the one that we see in patients with DADA2. We also found 4 individuals with monoallelic rare missense variants in ADA2. And the variants you can see here, the patient's variants. And patient number 1 carries a variant that was already described in DADA2 before, which is predicted to be deleterious and damaging to protein function. We were able to get serum samples for patient number 2 and number 4. However, when we tested the enzyme activity, we couldn't see a reduction in enzyme activity. So this excludes the diagnosis of DADA2 for these 2 individuals. However, the other 2, patients 1 and 3, could still potentially have DADA2 because maybe they carry a cryptic second mutation that we couldn't pick up by Sanger sequencing. And obviously, the ideal case would be to get serum samples from them, that sometimes this is not possible. So we now extend our laboratory approaches, and we also sequence areas, intronic regions and other non-coding regions of the ADA2 gene, and we test for copy number variations, so deletions or duplications in the ADA2 gene, because this is becoming more common in patients with DADA2. Okay, now we became curious, and we wanted to test other types of vasculitis for prevalence of DADA2. So we tested the prevalence of DADA2 in ANCA-associated vasculitis. Namely, we investigated a cohort of over 1,100 patients with granulomatosis with polyangiitis and microscopic polyangiitis. And these patients were also ascertained by the Vasculitis Clinical Research Consortium. However, we did not identify any patients with biallelic rare missense variants in ADA2, which underlines the importance of DADA2 in PAN specifically and not in other types of vasculitis, at least in these types of vasculitis. We found 33 patients who have monoallelic rare missense variants in ADA2. And I show you these variants, even though might be too much, but some of them are predicted to be deleterious, and some of them are already described in DADA2 before, but most of them are neutral to protein function. So we don't know exactly what to make out of this. So, and we also got our hands on a cohort of patients with migraine with aura. So we got 300 female patients with migraine with aura. And we wanted to test the prevalence of DADA2 in these migraine headaches. Because we already heard about headache with migraine in DADA2 carriers, in carriers for missense variants in ADA2. And also some headaches for migraine can be explained by underlying cerebrovascular disorders. So, and since DADA2 patients have impaired vascular integrity, we thought maybe there's an association. So 300 patients with migraine with aura, sequencing of the complete ADA2 gene in all 300 patients. And we found no patients with biallelic rare missense variants. However, we found 7 patients that carry monoallelic rare missense variants ADA2. So these are the variants. Some of them are deleterious to protein function and very rare. So this is actually higher than you would expect just by chance. Okay, to summarize, I showed you today that DADA2 accounts for a subset of patients with idiopathic PAN. It seems to be not prevalent in other types of vasculitis, such as granulomatosis with polyangiitis and microscopic polyangiitis. We didn't find any DADA2 patients in migraine with aura individuals. And this has important implications because we already heard several times today, and I think we now get the talk from Dan, who talks about the TNF inhibitor treatment in DADA2. TNF inhibitor treatment is not the mainstay of treatment for PAN, so it's important that these individuals are identified so they can be treated differently. Also, the clinical follow-up of these individuals is different, the prognosis, and also important, since DADA2 is an autosomal recessive disorder, it's important for the family members and for genetic counseling of these individuals. And I would like to end with some recommendations. So we think that testing for DADA2 is indicated in patients with idiopathic PAN, especially if they present early or earlier than other individuals. The testing can be performed ideally by ADA2 enzymatic assays, but can also be done by sequencing of the ADA2 gene. And with that, I would like to thank you guys for listening.